Hey again, everyone. This is Evan Wilson again. At the time of making this video, I'm a fourth-year resident in the McMaster Radiology program. So today we're moving on into part two of our CT head component of the McMaster Clinical Skills Radiology series. So in the part one, I talked about just the planes of imaging and the basic anatomy that you'll see on a CT head. So if you haven't seen that video or you don't have a good understanding of those concepts already, then you can go back and watch that video beforehand to kind of get a primer before we talk about today's approach. But today we'll just be going through a systematic approach and some basic pathology that's seen on a CT head with a focus on acute pathologies. So what are the objectives of today's video? Well, I'll describe what my systematic approach to interpreting a CT head is, and that'll include which structures and pathologies not to miss, and the most common pathologies that you'll see on a CT head. So what should you do when you're approaching a CT head? This is my approach. It's kind of an outside-in approach. I like to look extra axial space first outside the brain for any hemorrhage, and then inside the brain for hemorrhage. And then I move on to more of the brain tissue itself and the gray-white matter differentiation to make sure there's no stroke, infarct, or ischemia going on. And then I move even more essentially to the ventricular system of the brain. Right after I look at the ventricular system, I look at kind of midline shift and herniation. Is the brain moving into an area that it shouldn't be? Is there some gross overall swelling that's obliterating some of the basal cisterns? And then at the end of everything, I look at the orbits, the sinuses, and the bones and soft tissues. As we go through the video today, I'll be scrolling through an axial CT head of the brain. It's always going to be a normal brain, the axial image that I'm scrolling through, but I'll have some examples of the pathologies on the side and on subsequent slides. So as I scroll through the normal brain, I'll describe what I would be looking for, and then we'll see some examples of the pathologies on the other slides. It's important to note that, as with any other imaging study, there's really no right systematic approach to reading a CT head, just as there's no right approach to the way you look at a chest x-ray or anything else. The important thing is that you're systematic and you're not missing looking at any structures, and to be consistent between different studies. So if you're inconsistent, you could skip a step by accident and miss something. If you're reading many studies over the course of a long period of time, if you're consistent every time, you'll make sure you look at everything every time, and you'll have less of a chance at missing an important finding. So like I said, I use the outside-in approach, but some people use this blood can be very bad mnemonic, and that stands for blood. They look for blood first, cisterns, they then look for mass effect to make sure the cisterns, the CSF spaces surrounding the brain, are preserved. Then look at the brain tissue itself for mass, blood, infarct. They then look at the ventricles for any hydrocephalus or interventricular pathology, and then they look at the bones. The thing I don't like about this mnemonic is that some structures are left out. I guess maybe because they're housed by bone, the orbits and the sinuses are supposed to be included in the bone section. And then there's also the soft tissues of the neck that are caught at the top of the scan that's not really included in this acronym. So we'll walk through my approach kind of on a step-by-step basis, and that's the outside-in approach, and we'll just look at one thing at a time. So my first step in my algorithm is looking for hemorrhage, extraaxial first and then intraaxial. So as I scroll through this axial CT on the side of the screen, I'm scrolling slowly and just looking at all the outside of the brain spaces first, all the sulci, these CSF containing sulci, all throughout the brain, and really just scanning slice by slice, making sure to look at every one, as well as along the midline, for any abnormal hyperattenuation, which could represent blood. In a normal, healthy brain, it's important to know that when the brain's kind of full like this, good brain volume, the patient's not old enough to have lost a lot of brain. You don't always see the sulci throughout the entire brain, so don't be alarmed by that. At the top of the brain, you should start to see the sulci very nicely, though. If you're not seeing any sulci at the top of the brain here, then start to be worried that there's some swelling going on. So as I scroll here, I don't see any abnormal hyperdensity within any of the sulci, which could be a hemorrhage. It is important to note there are some hyperdense normal structures that do project in that area. Like for example, here on either side of this midline structure, which is the falx, are these dots of hyperdensity. Could those be bleed, you want to think? They could be, but as you scroll through, you see they continue in kind of a tubular fashion moving downward. So those are just going to be some small venous structures. There's also this more dense area here, which forms this triangle, and that's a venous sinus, particularly the superior sagittal sinus in this case. So that's a normal kind of increased density. If it becomes too dense, that can indicate that there's a venous sinus thrombosis going on, but that's kind of beyond the scope of the pathologies we're covering today. So I looked at all the sulci or surrounding the brain for blood. I then want to make sure I look at the cisterns. Again, we're not going to talk about the detailed names of the cisterns today, just because I like to keep these videos nice and short for your clinical skills curriculum and keep them clinically useful. But all these extraaxial CSF spaces lining the brain, making sure they all have the attenuation of CSF, and making sure that there's no abnormal hyperdense material, which would likely be blood, filling them. And I'm happy that all the cisterns are filled with CSF here. I then look at the intraaxial brain and just see, is there any intraaxial hemorrhage? Are there any dots or foci of hyperdensity that could represent blood? And I don't see anything. It looks normal. If I were to see hemorrhage, particularly extraaxial hemorrhage, you might see something like what's shown on this slide. There are a few different types of extraaxial hemorrhage. There's your epidural hematoma, which is outside the dura and has this lentiform shape and doesn't cross suture lines. There's a subdural hematoma, which is below the dura, between the dura and the brain. It tends to have more of this crescent-shaped appearance to it. Again, the acute blood is going to be hyperdense, I should say. So you'll notice this is a hyperdense epidural hematoma, a hyperdense subdural hematoma, which is more crescent shape, and it can cross suture lines. And then what's often a bit more subtle than the epidural hematoma and the subdural hematoma is your subarachnoid hemorrhage. And that's why when I was scrolling through on the previous slide, I was really carefully looking at all of the sulci that I could see, because this dense serpiginous material kind of invaginating in between the sulci is all acute subarachnoid hemorrhage. That's the extraaxial hemorrhage, but as I said, we need to scan the intraaxial brain tissue for hemorrhage as well. And these are some not subtle at all, very large examples, but you'll have traumatic contusions here on this side of the slide with some subarachnoid hemorrhage likely here as well. But big hyperdense regions representing acute blood within the brain tissue. It's not extraaxial or outside the brain tissue along the convexity. And often a good way of helping decide if it's intraaxial, aside from brain fully surrounding the whole thing, is they tend to cause more vasogenic edema or hypoattenuation directly adjacent to the bleed itself in the brain tissue. This is a large intraaxial bleed from a vascular malformation, large circumscribed hyperdense region within the brain tissue. And then also in this case, it looks like it extended into the ventricular system. So intraventricular extension of hematoma. And that was due to a vascular malformation. And then metastatic lesions can also bleed too. So there's a large bleed in the left frontoparietal region of this patient, big hyperdense area within the brain tissue. And then this rim of darker density compared to the white matter on the other side. So that represents vasogenic edema. And this ended up being a metastatic melanoma, which had bled. The lesion itself is obscured by the large resultant bleed. So that covers hemorrhage. What's next on my stepwise approach is to look for gray-white matter differentiation. This is one of the more, I think, the findings that radiologists tend to place a little bit more emphasis and time on when they're actually reading a clinical study, just because it can be one of the more subtle findings. And what you need to do, especially when you're worried about stroke, is look at every slice and look at the junction between the white matter and the gray matter, around the whole brain, and just make sure that it's a maintained junction. You don't want to see any complete blurring or when you see no difference in attenuation between the white matter and gray matter in any specific area. That's when you become concerned that there could have been an infarct to that area. As I scroll through here, I can see everything looks nicely preserved. The cortex is nice and white. There's a nice junction with the white matter and the gray matter really along the whole brain. And I also want to make sure that the basal ganglia are preserved as well, because in stroke, sometimes you can only lose the basal ganglia. So you want to see your caudate, your lentiform, and you also want to see your thalami. Something very useful when you're doing this can be to try and use symmetry, just to see if something looks a little bit more bright or well preserved on one side of the brain and not the other. That can call your eye to finding a potential infarct. Another important area not to miss when you're doing this is to make sure you look at the midbrain, the pons, even though it's limited by artifact in many cases, you still need to take a look to see if there's something obvious in case it isn't limited by artifact, as well as the cerebellum, which it can be a little bit trickier to assess because of the artifact from the surrounding bones, but you certainly can pick up infarcts in that area. And it's the same concept with the gray-white matter differentiation being lost. At this point, you also want to look for any intraaxial mass lesions, tumors, or any vasogenic edema that you can't explain, which would show up as hypoattenuating regions with no specific underlying lesion that you can't explain. So what does some of this stuff look like? Well, here's what a stroke would look like. This is a very obvious case. Another finding which we didn't talk about, but you'll see in the case of stroke, is a hyperdense vessel sign. So you can see here's the normal attenuation of a vessel leading into the left MCA, and then it becomes much more dense, and that's indicative of fresh clot within the vessel. And then in this patient, they had a resultant left MCA or middle cerebral artery infarct. And as you can see from what I was discussing in the prior slide, you can see this loss of gray-white differentiation both in the left frontotemporal region here, where you have gray matter going back, and you just have deep hypoattenuation similar to the white matter on that side throughout this whole region in the gray matter, indicative of an infarct. And then another thing that you'll notice is look at the caudate and lentiform on the right side of the brain, and then look for them on the left side of the brain. We're at the same level, so you should see them, but they're almost completely gone. So they've complete loss or hypoattenuation of gray-white matter in the caudate and lentiform as well, indicative of an infarct. I should note, if this looks funny to you, it's windowed differently than a lot of the CTs I've been scrolling through. This is specifically windowed for stroke. When we're looking at an imaging study, we can just adjust the display settings at our workstation. And this setting is to just really call to our attention the difference between gray matter and white matter. So this would be a normal side, and you can see compared to the prior slide when I was scrolling through, it really creates a stark difference between the gray white matter and white matter. So you can really pick up areas where that differentiation is lost a little bit easier. Okay, so I've looked for hemorrhage, I've looked for stroke, then I would move more centrally in the brain and look at the ventricular system. I want to make sure there's no blood within the ventricles. I want to make sure that the ventricular system is normal in caliber with no evidence of increased pressure causing hydrocephalus. And I want to make sure there's no lesions within the ventricular system. So I would start at the top and just scroll through the lateral ventricles and just make sure that they're normal in caliber, which in this case, they're nice and small, decompressed. I can't even follow the ventricle all the way to the temporal horn, which is normal on a young patient without hydrocephalus. And I want to look for any internal hyperdensity, which could suggest blood, or any mass within the ventricles, which I don't see any of. The one thing I should note is that you might see a little bit of hyperdensity in every normal patient, kind of along the region of the atrium of the lateral ventricle, here and here. And that's just normal choroid plexus. Your choroid plexus is a little bit more radiodense, and it shows up as hyperdense material within the ventricle. Don't mistake that for blood. Normally with intraventricular blood, there'll either be a lot more of it, or it'll be layering very dependently on the occipital horns, and you'll almost get like a layer of flat hyperdensity layering out because gravity is pulling it down, and it's settling dependently in the ventricle. So I want to make sure I look at the lateral ventricles, but don't forget about your third ventricle between the thalami. Don't forget to scan along the aqueduct to make sure there's no obstructing lesion. And don't forget to follow it into the fourth ventricle and make sure the fourth ventricle is also normal in caliber. So what could some pathologies look like? So here's a normal for comparison. Here's a patient with hydrocephalus, so massively dilated ventricles, really rounded and ballooned out. The cause wasn't stated in the case. And then here's an example of what you could mistake for hydrocephalus, but there's really a lot of regional volume loss in the frontal lobes and temporal lobes here surrounding the frontal horns of the lateral ventricles. And then posteriorly, the brain volume is a little bit normal, as is the ventricular caliber in that region. So there's a few reasons why this is most likely dilation related to atrophy and not hydrocephalus. It wouldn't really make sense for hydrocephalus just to be focal in both the frontal horns of the lateral ventricles, but not extending to the remainder of the lateral ventricles at all, because those spaces should be communicating with each other and draining into the third ventricle. If there's an obstruction at the level of the third ventricle, you should see dilation of one or both of the entire lateral ventricles and not just the bilateral frontal horns. And then also the dilation that we're seeing focally here is in exact conjunction with where the volume loss of the cerebrum is. So it makes sense that this is actually not hydrocephalus, but it's just reactive or ex vacuo dilation, as we term it in radiology, related to the volume loss around the ventricles, not to be mistaken for hydrocephalus. So moving on to our next aspect of our approach, we want to make sure that there's no midline shift being caused by mass effect and that there's no herniation. So as I'm scrolling through here, I want to find the falx cerebri, which is this band of dense tissue here in the midline, forming a nice straight line. And I want to follow it down and make sure it stays in the midline and it stays nice and straight and it stays in line with the septum pellucidum, which is this tissue barrier between the two lateral ventricles. If I draw a line from the front of the falx down back through the back of the falx and through the venous confluence at the back, which is this triangular structure here, the line that I drew should flow directly through the septum pellucidum, indicating that there's been no shift of the brain from the left or the right. In terms of assessing herniation, again, I want to look at my basal cisterns and just make sure that they're all nicely preserved. So in my prepontine region here, there's some preserved CSF. Posterior to the midbrain and the quadrigeminal cistern, it's preserved. In the ambient cisterns, you can see this thin line of CSF, which is normal. You can see the space between the peduncles. You can see this big suprasellar cistern kind of branching out into the sylvian fissures bilaterally. All those spaces look symmetric and preserved. If one of these spaces is obliterated and not the other side, then I start to worry that there's some kind of asymmetric mass effect or pressure, which is pressing in on that space and getting rid of the space. So what types of, midline shift first. So as I was saying, if you draw a line from the anterior aspect of the falx through the posterior aspect in a straight line, the septum pellucidum should fall in that line. In this case, you can see the brain's being pushed to the left side, which we call leftward midline shift. And the septum pellucidum is translated whatever this distance is to the left. And we can measure that distance and give a quantitative measure of how much leftward midline shift there's been. I'm assuming that there's a bleed in this patient. There's some irregular hyperdensity here, which I might be catching a part of a bleed. There's some soft tissue swelling on either side of the brain. So there's probably an underlying bleed, which they're only catching a very small part of, which is causing this midline shift in this patient. With regards to mass effect, we also want to look for sulcal effacement. So if you look at this brain, you can see there's really no sulci that we're seeing at all, pretty much throughout the entire brain. And that's another indicator that there's mass effect, compressing the sulci to the point where we can't see them. This schematic just shows different types of herniation, which I won't try to dwell on too much, but There's subfalcine herniation where you have gray matter going underneath the falx to the other side, which can be impinged and cause ischemia or infarct. There's uncal herniation. There's descending transtentorial herniation. And then there's tonsillar herniation when your cerebellar tonsils start getting pushed through the foramen magnum. They're all bad, but this is probably the worst one in terms of your immediate clinical outcome, because if you start pushing too much material into the foramen magnum, you can constrict your medulla, and which is responsible for really a lot of your basic functions, and you can really die very quickly in that scenario. So here's an example of tonsillar herniation. Here's a normal case. You can see this is a sagittal plane, so we're looking kind of from the side of these midline structures in the midline. You can see the cerebellum here and the brainstem here, and really just a lot of preserved CSF normal at the level of the foramen magnum with no compressed structures. Here we're seeing the cerebellar tonsils really project downwards through the foramen magnum, which is here between these two pieces of bone. And then it's kind of compressing on the brainstem structures. We're not seeing any preserved hypoattenuating fluid CSF space at this level. It's all filled with brain tissue, which is a sign that things could be becoming compressed in this patient. So that's tonsillar herniation. The bottom of the slide here, we show uncal herniation, which, as I was saying in the previous slide, you want to look at your basal cistern. So here we have the suprasellar cistern and the midbrain, nicely preserved. On the other side, we can't see any of the suprasellar cistern at the same level. We can also see what's called your uncus here, which is this medial projection off of the temporal lobe, which in a normal case, it just has a slight medial rounded projection. In the case of uncal herniation, that uncus actually projects into the cistern and obliterates it. So you're seeing this patient's uncus right here, completely obliterating that cistern. And in this case, they have a subdural acute hemorrhage here, which is this crescenteric hyperdense collection in the extraaxial or subdural space. Okay, so we're moving down to the next item on our list, which is the orbits. Unfortunately, this isn't really windowed properly to look at the orbits. We should be able to see some of the fat a little bit better than this, as opposed to it just being black. But I wanted to show everything on the same CT head. So it's scan through the orbits, make sure the globes are nice and round. You can see the lenses as well as the outer contour of the entire globe. It's nice and symmetric. And you can also see the extraaxial muscles and the optic nerve heading into the globe itself. So you want to look at all those structures, make sure they're symmetric, make sure there's not proptosis of one or both sides, which means the eye is projecting out too far from the orbit. You want to make sure you look at all the fat within the orbit and make sure there's no kind of irregular stranding or collection or mass there. You want to make sure there's no expansion of the orbital nerve as well. The next thing to look at is your sinuses. And again, not perfectly windowed to look at the sinuses. I would like to be seeing the surrounding bone a little bit better. But you want to see these air-filled spaces in the paranasal area. So your maxillary sinuses, your ethmoid air cells, your frontal sinus, and your mastoid air cells, as well as your sphenoid sinus here. You just want to make sure that they're all well aerated, which means low attenuating, filled with air. They're not filled with fluid. They're not filled with blood. They don't have some kind of mass or infectious process going on inside them that you might need to worry about. And you want to make sure that their walls are intact and there's no evidence of fracture. So here's an example of an orbital blowout fracture. Here's what I was saying when things could be windowed a little bit better. It's nice to see some density to the internal fat so you can actually assess the fat. In this case, here's a normal side, and then here's an abnormal side. So what you'll notice the difference between the two is on this normal side, there's a nice intact roof of the maxillary sinus. We're looking at a coronal image here. Nice intact roof of the maxillary sinus, and then the orbit is essentially a different structure from that. It should not be invading into the maxillary sinus. On this side, you have a defect within that maxillary sinus roof. You have fluid, which is this kind of hazy gray attenuation, or blood filling the maxillary sinus. You have some air at the bottom here still. And then you have this density, which is actually the same density as the orbital fat, projecting through that defect into the maxillary sinus and taking some of the extraocular muscles with it. So in this case, we actually have a blowout fracture of the inferior wall of the right orbit or the roof of the right maxillary sinus, which are the same structure, and then herniation of the orbital contents into that maxillary sinus. This is an axial image of a patient with similar findings. This is more of a medial wall fracture, where again, they have a nice intact wall on the right side. On the left, they have defect here. They have some fluid within the sinuses. And then they have a lot of gas within the orbit, which is this low attenuating kind of bubbles, as well as within the soft tissues just in front of the left orbit, which is all indicative of a trauma, a fracture, and then gas getting either from the outside environment or from the sinuses into the orbital cavity. The last thing we want to look at is the bones and the soft tissues. Unfortunately, if I was looking to assess the bones, I would have to window this differently for a bone window. But again, I don't have the ability to window differently. But I should be seeing some of the internal kind of texture to this bone instead of just a one white conglomerate in order to properly assess it. But essentially, I want to look at all the bones and make sure that there's no fracture, destruction, mass, or if there's any hematoma within the soft tissues of either the upper neck, the cheeks, or all around the scalp and orbital region. Really, you want to look at every part of the anatomy that you scanned and acquired, and make sure you don't forget about the soft tissues because it's the last thing that you look at on the study. And here's just a few examples. So this is nicely windowed for what the bone should look like. So you can see some of the internal architecture of the calvarium itself. So this is what your window should look like when you're assessing the bone. And then if you follow it along, you can see this defect here, which is a little bit of a depressed fracture in the right parietal bone. And so now that this is windowed to look at bone properly, it's not windowed to look at the intracranial structures, but even so, you can see this line right here, which indicates an extraaxial hemorrhage right here underlying this fracture. On this side of the screen, again, window to bone, so you can actually see some of the internal architecture, but instead of being nice and homogeneous like this, you have these kind of multifocal, punched out, lytic, destructive lesions kind of everywhere throughout the skull. And this is a case of multiple myeloma. Okay, so we went through my entire approach to a CT head. We talked about looking at the extraaxial spaces for any hemorrhage, all the sulci, all the cisterns. We talked about then going to the inside of the brain and looking for both blood, masses, vasogenic edema, which would be abnormal hypoattenuation, and gray white matter differentiation. We looked at the ventricular system for any hydrocephalus, any blood within the ventricles, or any lesions. And we remembered to follow it all the way down to the third and fourth ventricle. We talked about midline shift and assessing if this falx and septum pellucidum are nicely in the midline. We talked about herniation, which we'd see obliteration of the basal cisterns. In this case, they're all nicely preserved. We also want to look at the sulci to make sure that those are preserved as well. We talked about looking at the orbits and sinuses for fracture, mass, hematoma, asymmetry, proptosis. And we talked about looking at the bones and soft tissues for any traumatic findings or any incidental destructive findings like bony destruction, a mass, or any hematomas in the soft tissues. So that concludes my approach to reading a CT head, particularly an unenhanced CT head in the call setting with a focus on acute pathologies. Hopefully you took something out of the video. You now feel like you have some confidence in looking at a CT head and what some of the common pathologies might look like or that you're looking for as you scroll through it. Thanks for watching, and we'll see you next time.